عليكم جميعا.
عليكم السلام.
عليكم السلام ورحمة الله.
صوتي واضح يعني؟
صوتك واضح دكتور.
صوتي واضح، اوكي. السلايدات واضحة هسه؟
نعم
بلي دكتور.
فاين، اوكي. بسم الله الرحمن الرحيم. Our lecture today in the series of lectures of infectious disease is bacterial meningitis. Bacterial infection of the meninges. Meninges, the layer covered the brain and the spinal cord. In general, infections of the central nervous system, either a primary event affected only the central nervous system or part of systemic disease, like nowadays COVID-19, one of the complications of the COVID-19 infection is infection of the brain parenchyma. So it's not restricted to the central nervous system, but complicated from the respiratory system, part of systemic infection. An infection of the central nervous system may primarily affect the meninges, the covered layer of the central nervous system, or the infection of the brain parenchyma, the brain itself. But a patient may have more than one area affected and called it meningitis if it is predominantly affected the meninges, and call it encephalitis if the infection predominantly affected the brain parenchyma. Before starting discussion, infection of the central nervous system and specifically bacterial infection of the meninges, I want you to know what do you mean by infection, and we should differentiate this term infection from the other term inflammation. Infection denote the successful invasion, establishment, and the growth of microorganism in the tissue of the host. Is not enough to have the pathogen and establishment of the pathogen in the tissue of the host, but to growth, to say there is an infection. Many people now transmit COVID-19, but not infected in this pathogen. So there should be three factors: invasion, establishment, and the growth. Bacterial meningitis, it means invasion of the bacteria, establishment in the subarachnoid space of the meninges. Meninges is 3 layers between arachnoid layer and pia mater. There is a space called subarachnoid. Establishment of the bacteria in this area part and growth of bacteria there make us say there is infection. So invasion and establishment is not enough to make the infection. Is the reaction of living tissue to infection, injury, or irritation. It's the reaction. And it's very important to differentiate because many manifestation is due to inflammation rather than to infection itself. And inflammation is not necessarily a reaction to infection, but maybe to injury and to irritation in any material. Bacterial meningitis, our issue to be discussed today is an acute, purulent, قيحي infection within the subarachnoid space. So there is invasion, establishment, and the growth of bacteria in the subarachnoid space. It is associated with central nervous system inflammatory reaction, which give the clinical manifestations. There is usually a predisposing reactions, predisposing factors that its presence lead to bacterial meningitis. Patient with parameningeal infection, infection in area around or near the meninges. For example, upper respiratory tract infection, sinusitis, mastoiditis, can be a predisposing factor to bacterial meningitis. Mechanical defect in the meninges to the subarachnoid space. Meninges is a hard layer that protect the brain and the spinal cord. Any defect, يعني حتى لو كان كبر راس الدنبوس, invasion of bacteria from this small defect can lead to bacterial meningitis. Suppressed immunity. Maybe there is invasion and maybe there is establishment, but it will be killed by the immunity, the pathogen killed by the immunity, and prevent formation of infection, to complete the picture of infection. But suppressed immunity is one of the predisposing factor to many infection. One of them is bacterial meningitis. Alcohol use disorder, any alcohol use disorder can be a predisposing factor to bacterial meningitis. The epidemiology of bacterial meningitis. The annual incidence of bacterial meningitis is between 3 to 5 per 100,000 over all population. But the highest attack rate of bacterial meningitis is in children under 1 year of age, and falls off rapidly with increasing age. The most causative organism of community acquired, and there is many type of bacterial meningitis. Community acquired bacterial meningitis, usually by Streptococcus pneumoniae and Neisseria meningitidis, which is meningococcal. Meningococcal may occur in epidemic. Etiological agent. What is the bacteria that cause bacterial meningitis? It's difficult to memorize all the types of the pathogen that cause bacterial meningitis, but we should know. We should know the factors that we can suspect the pathogen in each patient. First, age-related. Below 3 months of age and above 50, we have a special type of bacteria. The route by which the infection is acquired, is it community acquired, or it's in hospital acquired, or in a patient with immune compromised, or in patient with head injury, and there is defect in the mechanical defect in the meninges, and so on. The presence of associated or predisposing factor. A patient with immunity suppression, we should suspect some type of pathogens. Nobody will ask you about these bacteria, but I want you to know the classification. So meninges in neonate and infants up to 3 months old is usually caused by these 3 types of bacteria. And recognize that Listeria found in this age. Spontaneous community-acquired meningitis in preschool children and are usually caused by these type of bacteria. In older children and adult less than 50, in spontaneous acquired meningitis, there is meningococcus and streptococcus pneumoniae. In adult greater than 50, Listeria now return back, and no possibility of meningococcus. It's only pneumococcus and Listeria. In patients with parameningeal infection, mastoiditis, sinusitis, otitis media, usually associated, even rarely, but there is a cases of a gram-negative anaerobe, often playing a role. Post-traumatic and post-neurosurgical intervention, staffing is very important, and E. coli. In patients with chronic depleting disease and pregnancy, Streptococcus, Listeria, Pseudomonas, E. coli, anaerobe is found to be the cause. So we should take in consideration these circumstances in patients with a chronic disease, which is have suppressity of immunity, and in a pregnancy, we should cover these type of pathogen. And according to this classification, we will choose our treatment. Pathogenesis and pathophysiology. Pathogenesis is the event can lead to the pathology, and pathophysiology is the change in the function that explain the clinical manifestation. I don't care widely to the pathology, but pathogenesis make you understand the condition, and pathophysiology can understand the clinical manifestations. Meningitis, bacterial meningitis, typically occurs through 2 routes of infection. Hematogenous seeding, if bacterial meningitis is usually secondary to bacteremic illness from distant site of infection. And direct contagious spread, if infection may result from direct spread from an adjacent focus of infection, اللي هي parameningeal infection. But if the source of the bacteria is distant site, it come to the subarachnoid space and hematogenous seeding. In general, colonization, collection of the pathogen is an upper respiratory tract infection in nasopharyngeal mucosa, and hematogenous seeding by bacteremia. The bacteria by the blood seeding to the subarachnoid space and should cross the blood-brain barrier and invade the subarachnoid space and establish in subarachnoid space. If growth in the subarachnoid space started, so there is an infection. And for this infection in the subarachnoid space by a bacteria seeding from seeding by the blood from the nasopharyngeal mucosa. Inflammation started, and the patient start to have clinical manifestations. The inflammatory reaction in the subarachnoid space by the immune system of the nervous system can lead to formation, can lead to initiation of the clinical manifestations. Vessels can pass through the subarachnoid space by the pus formed by the inflammatory reaction in the subarachnoid space, can cause inflammation and then obstruction of the vessels, and can lead to infarction in the brain parenchyma. And this explains why the patient with bacterial meningitis, which is outside the brain, caused manifestation or involvement of the parenchyma itself. The infection is not initially in the parenchyma, it's not encephalitis. The infection in the meninges, it is meningitis, but the inflammation of these vessels in the subarachnoid space can cause obstruction and maybe infarction of area in the brain and give what we called it focal neurological manifestations. The cerebral vasogenic edema, inflammation of the vessels, is not always cause obstruction and infarction, but maybe cause permeability, and the fluid goes outside the vessels to the tissue. These fluid collection in the brain can cause what we call it increased intracranial pressure, and increase the pressure inside the brain, make the cerebral perfusion of blood is decreased. Then there is a regular pressure inside our head. Increase in this pressure, decrease cerebral perfusion. The balance will be lost. So, what is the clinical features of a patient presented with bacterial meningitis? How we can suspect this patient have bacterial meningitis? We said the most common type of pathogen is pneumococcus pneumoniae. The source of pneumococcus pneumoniae is parameningeal infection, and maybe not parameningeal, but distance also from the respiratory system. So anyway, the pneumococcus infection, when it's secondary, meningitis, especially in pneumococcus pneumoniae, when meningitis is secondary to infection elsewhere, the presenting system may be those of original infection. In other words, this patient maybe have dominantly a manifestation of sinusitis, for example. And we should be in high index of suspicion that this patient may have meningitis, even the presenting manifestation of original infection, which is para-infection like sinusitis. The classical triad of manifestation of bacterial meningitis is 2 symptoms and 1 sign: fever, headache, and knuckle rigidity, which is what we call it neck stiffness. But neck stiffness is a sign. You should suspect, or you should routinely search for neck stiffness in any patient with fever and headache, because rarely the patient give hint by the history to neck stiffness. يعني ده يقول دكتور شو عبالك رقبتي ما اقدر احركها. Okay, fine, this is a hint, but it's not usually given by the patient. So any patient with fever, headache, neck stiffness, which should be searched for. كان استاذنا استاذ سرمد الفهد يقول ماكو فخر اذا الطفل يجي والامايه تقول لك والله دكتور رقبته عبالك مقضبه ما يقدر يحركها، وتدور وتلقى نك ستيفنس. لكن الفخر لما المريض يجي فيفر وهيدك and you do for neck stiffness and you found neck stiffness and diagnose this patient as a case of meningitis. Nausea, vomiting, photophobia are also common complaint. Neck stiffness, local rigidity, is pathognomonic sign of meningeal irritation. Meningeal irritation, not meningitis. And there is other causes of meningeal irritation, but meningitis, one of the common causes of meningeal irritation signs. And the present, if the neck resists to passive flexion, we did a passive flexion to the neck, and the patient have a restricted of movement. There is other sign. I will demonstrate that for you. Kerning sign and Brodnitsky signs are also classical sign of meningeal irritation. Because the involvement of a brain parenchyma in patient with meningitis, many patients have seizure. Raised intracranial pressure due to permeability of a fluid to the brain parenchyma, the patient may have manifestation of increased intracranial pressure. And according to that, if the patient not treated, the consciousness may impaired. This photo can you recognize the demonstration of Kerning sign? We put the leg in the hip in 90 degree and then extend. Put the lower limb in 90 degree and then extend the leg. If there is restriction here, because normally can reach 180 degree. If there is restriction, it is Kerning sign. Brodnitsky sign is the same maneuver for neck stiffness, but with neck flexion, if there is a flexion of the knee, we will demonstrate what we called it Brodnitsky sign. Brodnitsky sign is more significant in pediatric age group. Very difficult to elicit in adult age group, except in advanced cases. Yani the patient should have advanced cases of neck stiffness to elicit Brodnitsky sign in patients with age of 40, for example. But in pediatric age group demonstrated in all age group. By the way, meningeal irritation signs difficult to elicit in patient less than 2 years of age and more than 50 years of age. So according to that, we should have a high index of suspicion to those patients in this age group that the patient may have bacterial meningitis. Herpes labialis اللي يعني traditionally الناس تسميها حمى لطمة حمى. This is a viral infection, but surprisingly, this viral infection in the upper lip is associated with bacterial meningitis rather than viral meningitis. So any patient with herpes labialis, it is a stigma or denote that this patient have bacterial meningitis rather than the viral meningitis. So this type of viral meningitis associated with bacterial meningitis. In meningococcus especially, very rare to find in other pathogens, but in meningococcus, there is a rash developed in the skin. It is usually petechial, but and it started in the lower limb, then disseminated in the upper limb and the chest. The significance of this rash, it is alarming that this patient may have meningoxemia. It is septicemia of meningococcus, not bacteremia that seed the bacteria to the meninges. Septicemia, it means there is invasion to the blood, establishment of the blood, and the growth of bacteria in the blood. Any delay in treatment of those patients may progress to what we see in the next slide. But this test, before that, I want to demonstrate this test. We called it a glass test. Any glass can press this petechial lesion at not faded. This is confirmation that this rash is due to a meningococcal infection. As I said, this is alarming to acute infectious purpura fulminans. This serious problem is not, it is serious not because there is changing in the type of the rash from petechial to purpura. Purpura, it means blood under the skin. The significance that this manifestation, it means there is septicemia, and septicemia caused to systemic inflammatory response syndrome. There is overaction. There is dysregulation of the immune system response that cause disseminated intravascular coagulation, DIC. I don't know if you know what DIC, but you know it in the future, I think. You should, sorry. This DIC, disseminated intravascular coagulation, is a serious problem because it can lead to multi-system failure, and multi-system failure can be the cause of death. So the mechanism of this purpura is septic vasculopathy due to septicemia, but the associated multi-organ failure is the ultimate complication of septicemia, meningoxemia specifically, and the adverse, this is the adverse outcome of sepsis. there is associated shock state. If it is not multi-organ failure, the shock state, peripheral cyanosis, and gangrene of extremity. This gangrene may lead to limb loss, and we need to amputate the gangrene limb. So if there is not death, the patient may lose one or more of its limbs. So any delay in a treatment, even hours, may lead to this serious complication. بس رحمة من رب العالمين انه there is alarming for this problem. يعني البتيكيال هي alarming to purpura, alarming to more serious, and purpura is the marker for the most serious condition. The question now is how we diagnosed the case of bacterial meningitis. Okay, we know that this clinical manifestation, how it started, why he developed this manifestation, but how we diagnosed. We cannot depend on suspicion only. Early diagnosis and treatment reduce mortality and incidence of complication. And complication is serious in bacterial meningitis. So rapid detection of this serious problem is very important. The diagnosis depends on suspicious clinical symptom and sign. As I said, any patient with fever and headache, we should have high level of concern regarding bacterial meningitis and take in consideration these manifestations as the early stage of more serious problem. CT scan of the head is nowadays, you cannot do lumbar puncture without doing CT scan. We should do it as quickly as possible. CT scan can reveal a skull fracture, parameningeal septic foci, such as sinusitis, spinal epidural abscess, and exclude the possibility that it is not bacterial meningitis. Maybe this is a brain abscess. Then do lumbar puncture. The key to diagnosis and establishing etiology is examination and culture of cerebrospinal fluid. Ideally, the cerebrospinal fluid sample should be obtained before initiation of antimicrobial. Ideally, should be done. But we try to do it as soon as possible. The classical CSF abnormality, cerebrospinal fluid abnormality in bacterial meningitis are increasing opening pressure, turbid in appearance, pleocytosis, increased number of white BC, with the predominant of neutrophils, mild to moderate increase in protein concentration, decrease glucose concentration. This decrease measured according to the serum glucose ratio of less than 40%. العفو، صوتي واضح؟ سمعوني زين؟
نعم دكتور واضح.
شو لحد الان ما حد سال اي سؤال، فقلت خاف قطع وانا ما ادري. اوكي
لا
فاين.
لا
دكتور انتظرك تذكر.
لا if you have any question you can interrupt. لا يعني you're allowed to يعني open the mic and ask any question. The gold standard for diagnosis of bacterial meningitis is identification of meningeal pathogen. Okay, fine. There is this finding of cerebrospinal fluid abnormality, but the gold standard of the diagnosis of bacterial meningitis is identification of the pathogen. We have a three way to identify the pathogen: gram stain, culture, and detection of bacteria by DNA or polymerase chain reaction. Gram stain, maybe we can rapidly have the result, but is not sensitive. Culture is more sensitive, but it take 48 to 70 hours to be positive. PCR is not that rapid as we want. So the gold standard for diagnosis, it needs time, and losing time, maybe we lose the patient. So what we can do to overcome this problem, I will answer it later. Other tests, blood culture should be taken before administration of first dose of antibiotic. Petechial skin lesion, if present, should be biopsy. مع الأسف we didn't do that in our circumstances. Blood count, chest and skull radiography to identify the primary source of infection. Please remember, in our circumstances, there is something called partial treated meningitis. Because in our circumstances, يعني مع الأسف I rarely تنكتب nowadays in the textbook printed in the Western countries. بس هنا عمال على بطال ياخذون antibiotic. So there is something called partial treated meningitis. And remember that the physical signs, even investigation, may be modified according to the partially treated meningitis. What is the differential diagnosis? What is the condition should be differentiated from patient diagnosed as bacterial meningitis? Subarachnoid hemorrhage. So the meninges irritated by something else other than bacteria. Meningeal irritation signs is pathognomonic for meningeal irritation, but not always irritated by bacterial infection. Maybe irritated by subarachnoid hemorrhage, chemical materials like drugs intrathecally given, or sometime contrast for radiological examination. Neoplastic, there is infiltrative neoplastic condition like lymphoma, for example. Other type of meningitis other than bacterial meningitis, TB, which is common in Iraq, and viral meningitis. I will mention complication before treatment because a significant number of patients unfortunately presented with complications because of delay in neglection, delay in diagnosis. He seek medical advice, but delay in diagnosis make the complication happen. First, as we mentioned, septicemia. And septicemia can cause to a series of problems like multi-system failure, gangrene, and lead to limb loss or death. Cerebral infarction, cerebral edema, and raised intracranial pressure. Inappropriate secretion of antidiuretic hormone. This inappropriate secretion can happen with any infection and many neurological problem. Acute neurological problem will cause hyponatremia, and the patient may die from hypernatremia rather than from the infection and from septicemia. Hydrocephalus, subdural empyema. Hydrocephalus is if they're collected in intraventricular area, the ventricles will be the passage of the CSF will be obstructed, and there is expansion of the ventricles. Subdural empyema, this collection of pus in subdural space. Venous sinus thrombosis is a serious complication that the infection extended to venous sinuses. As you know, in anatomy, the brain have different arterial system and venous system. And venous system constitute of sinuses and intracranial veins. One of the complications of Haemophilus influenzae, specifically hearing and visual impairment, and sometimes cognitive deficit. The treatment. After all these introduction, if we cannot detect the specific pathogen and the culture delayed to 48 hours, how we can overcome this problem, how we can deal with this problem. Unlike most other disease, management of patients with suspected meningitis or encephalitis also, by the way, begin with empiric treatment, تجريبي. When bacterial meningitis is considered a possibility, blood culture should be obtained and empiric antibacterial and adjunctive therapy initiated. But empiric therapy is not haphazard. مش عندي شنو عندي قبالي انتيبايتك انطيه للمريض وبر الذمه انا انطيت انتيبايتك. No. There is a factors that we choose the empiric therapy. Empiric treatment is dictated by the likely causative agents and their antibiotic susceptibilities according to the age and clinical circumstances. Inshallah, after graduation and starting your career, تجوني يمنا هذا يعني what I will discuss how to give the empirical treatment is not necessarily to found it in the world. أنا دا أحكي لكم هذه ال factors بس راح تجون إن شاء الله تشوفون there is a protocol. يعني بس أكو أشياء تسألها الage and search for special circumstances for this patient and start the treatment according to the protocol. But this discussion, you should know how the protocol is written, why this patient is given this antibiotic and that patient given that antibiotic. Empirical therapy for bacterial meningitis in children and adults should include third generation cephalosporin. Since about 30 years, third generation was become the cornerstone of treatment of bacterial meningitis. Let's have a general agreement. If we search for special circumstances in community-acquired bacterial meningitis, empirical treatment in this patient, in children and in adult, is third generation cephalosporin. We choose ceftriaxone or cefotaxime. Ceftriaxone nowadays become widely used, with or without vancomycin, because resistant nowadays become more evident. But in our circumstances, we didn't detect this resistant until now. So we start only with ceftriaxone. If no adequate response after 48 hours, 48 hours is the secret number for change antibiotic. If we change, we will choose also another another third generation cephalosporin, which is ceftazidime. Ceftazidime is a special third generation cephalosporin that acts on Pseudomonas. Another option as a second line is the fourth generation cephalosporin, which is cefepime or meropenem, a carbapenem antibiotic, which can be substitute the the third generation cephalosporin therapy. Ampicillin should be added. Unfortunately, third generation cephalosporin will not affect Listeria. Listeria found below age of 3 months and above age of 50 years of old. Ampicillin should be added to empirical treatment in patient below 3-year-old or above 50. Metronidazole may be added if there is clear evidence of parameningeal infection. As I mentioned in etiological pathogens, that in parameningeal infection, there is a possibility, even rare, there is anaerobic infection, anaerobic bacterial pathogen. In other circumstances, which is in hospital acquired, لا المريض أخذها من المستشفى, and in patient immune compromised and in post-traumatic, مضروب على راسه, ادى history of head injury وصارت. In a neurosurgical patient لا, سووا له كرينيوتومي, فتحوا المننجيز for يعني for brain tumor, for any cause, and the patient develop meningitis. Empirical treatment should be started with combination of ceftazidime, vancomycin, because in those patients, in these circumstances, hospital acquired, immune compromised, post-traumatic, and neurosurgical patient, Staphylococcus and pneumococcus should be covered and cannot be covered by ceftriaxone only. So we're starting with both ceftazidime to cover the Pseudomonas and vancomycin to cover Staphylococcus. In immunocompromised, specifically, ampicillin added because Listeria can be the cause in patient with immune compromised illness. In post-traumatic and neurosurgical patient, there is a possibility of anaerobic bacteria, so metronidazole should be added. Using of corticosteroid in patient with meningitis. There is controversy about starting corticosteroid, and is not a routine use, and if it is used, should be used before the first dose and continue only for few days. Once, so we start the treatment, empirical treatment, and after 72 hours, the result of the culture, we can obtain the result of the blood culture or CSF culture. Once the etiological agent has been isolated and its susceptibility determined, the empirical treatment should be changed if necessarily. If the patient improve, there is no need for change antibiotic. I usually treat a patient, not treat the result of the lab. So if the patient improved, don't touch, don't change anything. I hope it is clear. General management of complication. Management of airway, maintaining oxygenation, giving sufficient intravenous fluid if the patient with disturbance of consciousness or multi-organ failure or something like that. Any symptomatic for fever should be treated. Rise in the cranial pressure should be decreased. Seizure, we may start with anti-epileptic drugs. Hyponatremia treated in fluid restriction, because the cause of hyponatremia, as I mentioned, is inappropriate secretion of ADH. So there is dilution of sodium. So there is no need for replacement of sodium. Only fluid restriction can correct the sodium level. Prophylaxis. Household and other close contact of patient with meningococcal infection, especially prophylaxis should be given. And nowadays we give ciprofloxacin. Prognosis. We mentioned that the pneumococcal infection usually presented with the original infection, but the long-term complication is more in meningococcal. In pneumococcal, In meningococcal infection, mortality doubled if the patient presented with feature of septicemia rather than meningitis. What will kill so the early treatment of meningitis to prevent this serious complication. أنا من كنت بالقرى والرياض، كانت أهل الديوانية يعرفوها، كانت بمدينة اسمها الدغارة، تبعد يعني مو أكثر من 10 كيلو عن مركز الديوانية. بس كنت أنطي الفيرست دوز before sending the patient to the center of the city. أقول إيش مدري ما يكون ذاك الوقت أكو بالطوارئ فد يعني كاجواليتي، فد سيارة يعني كبيرة مقلوبة عندهم، فد 10-20 هيد انجري، يعني many problem. يكون neglect this patient for hours وتصير complication. حط الفيرست دوز وين ما كنت empirical therapy and send the patient to the centers. What is the factor that worsen the prognosis? I think empirical therapy should start as soon as possible, but there is a factors that motivate you to start it earlier. Focal neurological signs, seizure, disturbance of consciousness, complicated illness, delay in diagnosis and treatment, extreme of age, low CSF count, low sugar, high protein, and in shock state. ذولا مو تخليهم بالاسعاف وتقول ايه لا مو هذول اكو these factors يعني البروجنوسيس بور تخليه يوصلون لا. You should deal with them as early as possible. Even يعني give them what you can give. Treat the shock state, give the first dose of antibiotic, stop seizure, whatever. Because any delay with this factors make the prognosis worse. And thank you very much for your kind attention.
دكتور بلش احنا بس سؤال.
ايه تفضل.
المننجايتس احتمال